Okay, let's go. Welcome to everybody. In the next 1 hour, we will discuss some results of some sub-project of Spoke 2. My brief introduction is only to illustrate the organization of the Spoke 2, which is a spoke which deals with predictive and preventive medicine in different clinical settings. So we have organized all the sub-project in, as you can see in the slides, in 5 area, the area of public health medicine, primary prevention and early diagnosis, advanced technologies and biomarkers for preventive medicine, alternative predictive methods to animal testing, and drug design and development of innovative treatments for preventive medicine. And so the spoke includes 24 sub-projects, as you can see, 5 for the first area, public health medicine, 2 sub-projects for primary prevention and early diagnosis, 10 for the area of advanced biomarkers, divided in biomarkers for response to therapy and biomarkers of disease severity or progression of disease, 2 sub-projects for in the area of alternative methods to animal testing, and 5 again for drug design, discovery and development of innovative treatment. The time in this next hour, we will discuss the following projects. For the area of public health medicine, Professoressa Baccini, which is the PI of this project, and Professoressa Becchini, and then we will and then we will discuss these 2 sub-projects, which both of these projects have the same focus, male infertility from a laboratory point of view, Professoressa Baldi for method of fertility preservation in prepuberal males, and from a clinical point of view, Professoressa Vignozzi for the evaluation of new predictive biomarkers in the development of a healthcare system for prevention of male infertility. And okay, I can do. And then for the area of biomarkers for disease progression, we will discuss the results on multiple sclerosis from the research group led by Professoressa Amato. And finally, innovative treatments to improve preventive medicine from the group of Professor Baldini. So this is all. This is my brief introduction. And so I have the pleasure to introduce Professoressa Baccini.
Thank you. Good afternoon. I will present part of the results of this project, Environmental and Population Health Impact Assessment in Tuscany. We know that air pollution has negative effect on population health, including an increase in mortality from all natural causes and exacerbation of pre-existent health conditions and so on. And it's known that air pollution can have long-term effects or short-term effects. Long-term effects are the effects that appear years after chronic exposure, repeated exposure to air pollution. while short-term effects are the effects that manifest after few days from a peak of exposure, for example. It's well known in the literature that long-term effects are stronger than short-term effects. However, investigating the short-term effects is very important because it's useful to quantify the immediate burden of disease caused by the current level of exposure, and additionally can help in designing public health intervention that can have immediate effect on population health. Oh, sorry. In this part of the project, we use daily data regarding mortality in 8 municipalities in the surrounding of Florence for the study period 2008-2019, and also the daily level of exposure of the main air pollutants that are present in the urban areas, in particular particles, PM10 and PM2.5. And we obtained these results. On average, during the study period, we found that the number of deaths increases by 1.46%. This is the short-term effect of air pollution for each 10 microgram per cubic meter increase in PM10, and a very similar results also for PM2.5. But, so there is an effect of these two air pollutants on mortality. But the question is this effect constant over time, or this effect changed during the study period? We found that this effect changed over the study period. In particular, we can see that the effect, which is represented here for the two air pollutants, PM10 and PM2.5, is lower during the first year in the study period, and then increases with a peak around 2015, and then there is a slight decrease in the effect on both the air pollutants. So this is not reassuring about the safety of the air that we are breathing now, because there is an effect which is higher in the recent years, even if the level of the air pollutants, which is represented here by these segments, decreased over time. So there is a decrease of the air pollutant level, but at the same time the effect increased. So which is the reason of this behavior, of this time behavior? A partial explanation of this behavior can be this one. Maybe the dose-response function that is represented here for the two air pollutants can be not linear. So the dose-response function has this shape. So the effect here is represented by the slope of the function of the curve. So when the curve is steeper, the effect is higher. So this means that when the level of air pollution is lower, like in the recent year, the effect is higher. The curve is steeper. This can be a partial explanation, but is at the same time confused with other possible reasons for the behavior that we observe over time. So these are our conclusions. First of all, our finding stress the fact that the impact of air pollution on mortality is dynamic, and it changes over time, and probably and partially is influenced by a nonlinear dose-response function. But at the same time, we cannot exclude the role of other factors. For example, changes in pollutant composition, in particles composition over time, or interaction with temperature. When the temperature is higher, for example, during the 2015 temperature was very high during summer, this could a reason for this interaction between air pollution and temperature can explain the higher effect in sun year during the study period. But a general message is that moderate and low exposure are not safe. So, and also it's important to stress that in this small analysis, we considered mortality, which is only the tip of the iceberg, because air pollution can affect health in many different ways, not only with mortality, which is at the top of the effect. And so the message is that we need to reduce emissions as much as possible and as soon as possible. See, so this is the final message of our results up to now. Thank you.
Thank you. The discussion at the end, and so I introduce Professoressa Becchini.
Thank you so much. It's a pleasure to be here with you. And now I want to illustrate the results of the many objectives of the project ITOP. And we developed some toolkits for the surveillance of infectious diseases and also for the monitoring of vaccination coverage. But one of the objectives was to increase awareness about vaccination in the population. So, I will present the many objectives, because in public health it is important also to have acceptability about vaccination by the population. So in this part of the project we propose version 2.0 of one web page, which is called Find My Vaccine. In Italiano, Trova il mio vaccino. This is a digital tool based on the previous national immunization program, which was released in 2017. And in this project, the website was updated according to the new national immunization plan. Find My Vaccine is a digital tool which involved citizens but also public health providers, and with the aims to make it quickly accessible the information included in the national immunization plan, and so to make available to all people. The validation phase was performed in September and is still ongoing, and it is performed by specialists in public health at national level. The results of the first years before the update will be presented at the National Congress in October in Palermo, a National Congress of the Italian Society of Hygiene. A second point was to activate vaccination pathway inside the hospitals, and in particular with the collaboration of the main hospital here in Florence, the pediatric one, Meyer, and Careggi Hospital, two different vaccination pathways were activated in order to give people with the particular high-risk group, such as HIV-infected adult patients or subject with anatomical and functional asplenia, to access in a quick and easy way vaccination, which are very, very important for this kind of patients. Another point was to activate vaccination offer for pregnant women, and in this case the elaboration of the protocol has been completed, but the implementation is not really performed now at Careggi University Hospital. But the rationale is opening a vaccination center inside the hospital in order to increase vaccination coverage, which is very important for pregnant women, vaccination against pertussis, and vaccination against influenza in particular. We can go to the extensive molecular analysis which are performed by the Laboratory of Immunology and Molecular Microbiology at Pediatric University Meyer Hospital, and in particular the implementation of the regional pediatric network can increase the epidemiology and the knowledge about the circulation of some bacterial and virus which are involved in the health of pediatric people. So, another important point is the implementation of molecular surveillance databases, and especially for vaccine-preventable invasive diseases, and the assessment of the effectiveness of vaccination and potential vaccine escape processes. Another point is the study and cost-effectiveness study for preventable diseases, which is important in order to add new vaccinations even in the National Immunization Plan. As the last point I want to show is the development of a web application which can be accessible via computer or mobile devices, designed to collect periodic feedback on vaccination experience from people who attended the vaccination pathway. And another objective was to assess the satisfaction with the vaccination experience, provide accurate and up-to-date information on national and regional vaccination recommendations, and finally also to assess the access to vaccination information by the use of a standardized questionnaire which investigate the adult health literacy, so in a theme of vaccination. We received a purchase quote from one Florentine Azienda, enterprise, I don't know, for the design of the web application. Now we are providing this purchase to the university administration for approval. In the meantime, we are preparing the documents to be submitted to the university's research ethics committee in order to complete all steps by the end of the year. Other activities are in progress within the ITOP project contribution, and so I wanted to share this work in progress, both inside the Department of Health Sciences and also with the Meyer Hospital. So our activities are in line with expected results at the end of the second year. Thank you. I want to thank also the project team, which belong to the Department of Health Science from different sections, and Department of Neuroscience area of Medicine and Child Health. Thank you for your attention.
So we move from the area of public health medicine to the area of primary prevention and early diagnosis, and I introduce Professoressa Baldi. And then Linda.
Thank you. So good afternoon to everybody. The aim of our project is to set up a new bank for fertility preservation of prepubertal boys who need it because they have to undergo chemoradiotherapy that can compromise their fertility. The first milestone of our project was about training the recruited personnel in centers that already perform this procedure, and then to validate the technique within our laboratory. And this is what we have done. We sent 2 people from our lab, Lara Tamburrino and Maria Emanuela Ragosta, to 2 different laboratories in Europe, one in Münster and the other one in Brussels. These 2 laboratories are performing testicular tissue cryopreservation from prepubertal boys since about 10 years, so they have a long experience. And then we asked Dr. Stine Christensen from the University of Copenhagen to come to our lab to teach us the method that they use in Copenhagen. Also, this laboratory has a long time experience. So this is the method that we use to validate the technique in collaboration with Anna Maria Morelli and Giulia Guarneri. What we did is to test first the testicular morphology. This was done, of course, in an adult donor. And as you can see, the staining reveals the histological characteristic of the tissue. And then an important thing is to demonstrate that in the tissue are present spermatogonial stem cells, otherwise it's not worth to go on to cryopreserve the tissue. And so again, we use a specific probe for spermatogonial stem cells, which is an antibody directed again a protein which is present in these cells. The antibody is called MAGE-A4. And as you can see here, indeed, in the tissue, this is an adult testicular tissue from an adult person. As you can see here, the cells are very nicely marked with this antibody. Actually, we have already enrolled the first patient. We call patient number 0, and he was 11-year-old, but unfortunately, when he came to our attention at the Mayer Hospital, because the project is in collaboration with Professor Masieri of the Mayer Hospital, he already had several cycles of chemotherapy. And as you can see here, the tissue did not really preserve the architecture as it should be. At the same time, at the same time, as you can see, there was no major A4 positive signal in the tissue. That means that there are no spermatogenetic cells, stem cells within the tissue. This also after cryopreservation. So basically, this tissue was not worth to be preserved. This is another patient, age 13, and in this case, as you can see, both the histological characteristic and the presence of stem cells, are preserved. As you can see here, there are stem cells in the tissue. One thing which is important to say is that the two technicians, the two biologists of our lab experienced the fact that in the two centers where they went, actually the method that they used to cryopreserve the tissue was different. So one thing that we decided to go on with this project is to understand which one of the two methods behave better in preserving the characteristic of the tissue. And we are now doing that using testicular tissue from rabbits with both methods. I cannot go into the details of the two methods. And so far, we started with the first rabbit, and we start first of all to see if our antibody against stem cells was working, and indeed it was. As you can see, also in the rabbit, we can visualize the presence of stem cells with this antibody, so it means that we can go on with this project. And so far, we have cut the tissue of the rabbit with the two methods, but we still don't have the results for the moment, but of course we are going on with this project. The second milestone, where we worked a lot together with Professor Masieri and other people within the Mayer, was to create a network of specialists, and the idea is that this network should consider each case to decide whether it is worth or not going on with the cryopreservation of the tissue, and also to try to disseminate our activity within Tuscany. So what we have done, we created this activity, and these people, this multidisciplinary group will meet within Mayer and is formed by the people that you see here, but basically a pediatric urologist, Professor Masieri, two endocrinologists, an oncologist, a pediatric oncologist, and also a psychologist, which is very important to understand all in a holistic way the possibility really to go on with this patient. And we also develop two brochures, one for the families and the other one for medical personnel to show them what we are going to do. And with that, I finish, and I thank you for your attention.
Thank you, Elisabetta. So now the other part of the sub-project was related to the clinical part of the predictive issues related to male infertility, and so what we did actually is to try to also to support this part of the project by adding some inputs about the contest, and indeed what we can find actually is that the male part of the infertility couple are always overwhelmed as diagnostic and therapeutic procedures. So these are the activities, for example, of the Italian assisted reproductive technique centers in 2020. As you can see here, there is a lot of issues related to the male part that are under diagnosis. As you can see here, no causes are inside this block, and in contrast, when you look at the female part, you can see that a lot of causes has been diagnosed and even treated. So what we are missing here is to try to disentangle the underlying mechanism of male factors related to the couple infertility. So it's very relevant because we have a gender medicine issue here, and the male factor is actually under-investigated, understudied, underdiagnosed, and undertreated. So, and the other part of the story is that always in the clinical part, we are seeing patients that are only looked at by the medical doctors as for their fertility potential, only looking at their sperm analysis. So what does it mean? That the whole body is not sometimes be evaluated, and a lot of information are lacking. So actually also the World Health Organization stated that the semen analysis is never prognosis for couple infertility, and also alteration in semen parameters may be associated with a lot of individual healthcare problems. So we need to assess carefully also the male part of the story, because we can see that the lack of andrological assessment leads to consider couple infertility male-female driven issue. So it's a very not gender balanced, and because also missing prevention and diagnosis of several male diseases that can have an impact of the male reproductive function, and also be a mirror of oncological and cardiometabolic risks. So we need to make this assessment in order also to have an appropriate therapeutic decision for the couple. So it's actually the truth, because what we can see that always the couple infertility should be managed as with an accurate diagnostic workup, with all the medical treatment that should be done before going forward in this issue. And so to see if there is a pregnancy, so we are facing a reversible condition, then we can have some irreversible condition that should go to the assisted reproductive technique. This is very expensive, not only for the cost, but also for the emotion and the couple wellness. Is a very tough procedure. So we can have pregnancy, then we can have no pregnancy and move forward in the process. So actually we are missing a lot of information because we are not good in performing obtaining pregnancy, even in the art technique condition, and we are almost less before 40% of couples can reach this goal. So what we need is to try to make some procedure before considering the pregnancies as irreversible and not obtainable by using medical treatment. So what we decided to do in this sub-project was to develop an andrological service with the local primary health network in order to enhance our way to manage the couple infertility and to find the male factors underlying the problem. So what we did here was to create a center that was dedicated the first part of the story in order to make all the assessment and to treat the reversible part of the story. And so we set the center, and we were able to start the recruitment of the first andrological patients inside the center. So in this center, we make an assessment, an integrated assessment between the endocrinologist, andrologist, and the OB/GYN in order to make all the assessment for the infertile couple and to tailor the approach and tailor the therapeutic workup for the couple. So what we found, I will present you the data. So we established all the staff, the administrative staff to go in the territory, and what we found is that the first results, so we are very lucky because we started the project having aimed to have 50 couples enrolled. Actually, we are now 269 male subjects of infertile couple. These are the mean age, and what everything we are doing in this patient. And then we have also longitudinal studies, so we were able to recall and to see the destiny of this couple. So what we found was actually that is in young patients, we found a lot of metabolic alterations, so obesity in 12%, hypertension, dyslipidemia, metabolic syndrome, and even diabetes mellitus that we diagnosed by ourselves during the assessment. So there is a lot of information here stating that we need to assess all the medical alteration. And what we found was that all these medical metabolic alterations were related to sperm progressive motility, normal sperm in our patient, and only dyslipidemia maintain a negative association with sperm progressive motility after adjusting for confounders. And please take notes that sperm progressive motility is a very predictive parameter of a semen analysis of the reproduction during ART technique, so it's very important. And then we have a longitudinal study, and we were able to see spontaneous pregnancy at term in 11 couples. So only assessing and treating the main alteration. And then we have some couples without spontaneous pregnancy at term. So needs having a baby in your arms at the end of the story. So it's very important. And what we observed that no one of the conventional sperm parameters were different between the two groups. That means that it's not so relevant as we thought before. And what we found was that the couples with the pregnancy at term has a lower, the male part has a lower LH. There's a parameter that reflects about the integrity of the hypothalamic pituitary gonadal axis. And the main important part of the story was that we found that the severity of obesity, the visceral fat degree, and also the metabolic age were the only parameters that were different between the two groups. So no difference in a lot of hormonal level, no difference in the sperm analysis, but difference in what is the metabolic alterations. And then we make this rock curve in order to find, to disentangle the main parameter that was associated with the outcome of pregnancy. And what we found was that the best accuracy was related to the metabolic age, that is an age that correlates with a lot of information inside the body, not only the metabolic one. And it was indeed related to the blood pressure, LDL cholesterol, but also insulin levels. So it increases a function of this alteration, but also it reduces a function of total testosterone level in our male as sex hormone binding globulin, free testosterone, and TSH. So it means that maybe can reflect something that is more complex than the sperm parameters, but also the metabolic syndrome, and even considering a lot of information about the hormonal level. So, and the metabolic age also reduces a function of physical exercise entity and also the intensity of physical exercise. So finally, at the conclusion, we were able to find that we are starting to find a new predictor of the the pregnancy, the spontaneous pregnancy rate in our couple. So assessing and having a good assessment, also the male part can add very important information about the destiny of our couples, and even maybe drive some important information to target before going forward in the process. So I would like to thank my collaborators at the University of Florence and all the staff that work with me in this project. Thank you very much.
Thank you, Linda. Thank you, Elisabetta. And so we move in the area of evaluation of possible biomarkers for disease severity or progression of disease. And we start with Professor Amedei, which will illustrate his results on microbiota and heart failure.
Thank you for this possibility to present my results of this project. Okay, so it's very important to remember that we can have a director of this lab, Mia Lab. Mia Lab is in a laboratory focused on microbiota immunity axis. And oh. What is that? To change? No? Okay. 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 This is the title of my sub-project, and as you can see, the project is focused on heart failure, atrial fibrillation, intestinal bowel disease. This disease share and two very important factors. The first is the chronic inflammation, and another one is malnutrition. And so the principal aims of my study is to discover new biomarkers to prevent the undernutrition and also the inflammation by using an high approach. And the second and the most important is to develop the chocolate bar with chocolate and probiotics, in addition to all the other micronutrients, to contrast the inflammation and also the malnutrition. And okay. And this is the different milestone, and the first milestone, and what a different deliverable associated. And as you can see, we can obtain all the milestones that we can have planned. In addition, so we can have also a panel recruitment of the people, and in particular, we have recruited and 3 years technologies, for 3 years and PhD, and for 1 year and fellowship. Okay, and regarding the bar, the realization and development of the bar, okay, we have no problem regarding the development of the bar for the people, for the patients with heart failure and atrial fibrillation. So we can realize, and after we can test, and so this is good. And because of the first problem is it's good or no, it's because we can plan it and administration for 3 months. So it's very important the portability of the bar. So in this case we have no problem, and as you can see we can have the mixture of the dark chocolate, probiotics, and in addition so we can inulina and CoQ10. And regarding the second bar, the bar for the people, for the patients with IBD, in these cases we can have more problem because we can include butyrate and omega-3, and so in these cases the bar is very disgusting, so it's not good. And so we can do testing in my lab and also in that people. So after the it's very, very hard to digest and so also to eat. And so we can change the composition, because we can, yes, okay, we can have the dark chocolate because it's very important. In addition, we can have the probiotic Simpio, but it's different for probiotic of the first bar. And in addition, we can have the change for the butyrate and the omega-3 for hydrolyzed protein and vitamin D3. Okay, and after we can obtain the both ethical committed for the both study, because we can one study include the patients with air failure and atrial fibrillation. The second, so in these cases we can spend more time because we can change the composition of the bar, and so we can reapply to ethical committed. And now we have both the ethical commitment. In addition, so we can have one of the milestones is the acquisition of the new instrument to evaluate the cytokine profile, and so we can buy this ELA. ELA instrument is a very relevant instrument because we have the possibility to evaluate in very, very low concentration, picomolar, the cytokine profile. And regarding the second milestone, so we can have a different deliverable. The first is the patient's enrollment, and the second is evaluation of nutritional, inflammatory, and gut microbiota profile. Okay, and regarding the enrollment of the patients, you can see we can have a big disparity, because in these cases we can have no problem for the bar chocolate. We can obtain immediately the ethical commitment. Oh, immediately, so but it's for different mouse, so it's a big word. But so we can have 46 patients, and 22 is in the treatment for the chocolate bear, and we have no problem regarding the patability and so the side effect. But regarding the IBD, so we can have in 0 patients, because you have the very problem for the enrollment, because I have spent a long time to change the ethical commitment. And finally we can obtain, and now we can start, by obtain in the end of the summer. So we can start now I hope, the enrollment of the patients. And this is the timeline of when we can have the collection of the samples. So we can have it on T0, when we can have the enrollment of the patients after the 3 months of the treatment with the bar, and finally after T2 is after 6 months of the treatment of the bar chocolate. And this is the samples collected. We can collect the serum and urine, so the stools, and also the saliva, because we can evaluate, for example, in the serum, I used to evaluate the parameters associated for the inflammation, so we can evaluate the inflammatory signature. Use saliva and the fecal samples to evaluate the microbiota and also the functionality of the microbiota. And finally, we use different questionnaire to evaluate the nutritional, for evaluation of the nutritional status of the patients. In addition, the BIA to evaluate also the assessment of the body. And regarding the biomarker, because one of the aims is to discover a new biomarker, a new set of biomarker. And you can see this is the different parameter that we can evaluate, for example, in the blood and saliva, and also in the stool, regarding the inflammatory biomarker. Regarding the lipid biomarker, also in fecal and blood, this is all the parameter that we can evaluate. And finally, this is the characterization of the fecal and saliva microbiota. And finally, we can evaluate also the metabolic profile of the microbiota, because it's very relevant to characterize not only the composition of the microbiota, but also the production of the metabolites. And finally, because one very important point is integration of this data, because this is a very, very big data, okay? Big in the number, but also in the complexity of the data. And so we can realize a semantic knowledge base to harmonize annotation and representation schemes for different clinical and experimental data category used in this project. And in addition, so we can develop an experimental annotation template, data type models, and corresponding LTR pipelines for respective data integration, because this is very important. And so we have realized this database, and so we can put the different data in this database. More complex for me, yes, but I have the partner dedicated for this one. And so in conclusion, I want to thank the different people that we can support me in the enrollment of the patients, in particular Professor Fumagalli for the fibrillation patients, and Stefano Carinci for the Crohn, for ABS. And okay, there's my unit that will support me in this project, in more other project. And thank you for attention.
Thank you, Amedeo. And now I introduce Professor Amato for biomarkers for progression of multiple sclerosis.
Thank you, Rossella, and good afternoon. Posso avere la prima diapositiva? Yeah. Okay, it's great to have this opportunity to share with you our project and some preliminary, but we feel promising results. So multiple sclerosis is the most frequent and important demyelinating disease of the central nervous system. It is a multifactorial disease with an autoimmune pathogenesis. It involves mainly young adults, particularly females, in the most active and productive period of their lives. And it has a chronic course, and if not treated, it can lead to progressive physical and cognitive disability with high societal costs. Is in fact one of the most important causes of neurological disability in young adults. Italy is considered a high-risk area for multiple sclerosis, and it is estimated that 100,000 people live with the disease in our country. So over the past 2 decades, the therapeutic landscape of the disease has dramatically increased and improved, with more than 20 molecules approved in the market. At the same time and in parallel, the diagnostic criteria have also evolved over time, allowing earlier diagnosis for earlier treatment and prevention of disability progression in the long run. So the current scenario is characterized by early diagnosis and early treatment, availability of different therapeutic options with different safety and efficacy profiles and risk to benefit ratio. Which calls, of course, for accurate prognostic profiling of the patients in order to tailor the aggressiveness of our therapeutic choice, and of course the need to discover reliable prognostic biomarkers. Against this scenario, the main aims of the project were to identify MRI, genetic, serum, and cerebrospinal fluid biomarkers, prognostic biomarkers, in an early stage of the disease, and to identify a combination or pattern of these biomarkers that is more capable to predict subsequent disease course. As a secondary aim, also to test the capability of this pattern of biomarkers to predict treatment response. So we recruited patients with multiple sclerosis consecutively referred to our MS center who had a first assessment within 1 year from the clinical onset of the disease, so really an early stage of the disease. And our clinical assessment included the assessment of disability on this EDSS scale, and also we provided a neuropsychological and psychosocial assessment using well-validated scales for cognition, depression, and fatigue. MRI assessment was performed using a 3 Tesla scanner to measure total and regional brain volume, lesion load, spinal cord assessment, and we also looked at CSF biomarkers, particularly biomarkers of microglial activation, serum biomarkers, and especially the neurofilament light and GFP, and our genetic analysis focused on the polymorphism Val66 MET of the brain-derived neurotropic factor and the polymorphism epsilon-4 of the ApoE. So brain volumes and lesion volumes were obtained using an algorithm based on convolutional neural network. And we also assessed these slowly expanding lesions that literally are lesions that tend to increase in their volume over time and are emerging as a powerful prognostic marker of a more aggressive, more progressive disease. And notably, we were able to find these lesions in almost 60% of the patients after only 3 years after the diagnosis. We also calculated the volumes of different subfields of the hippocampus and the nuclei of the thalamus. So these are some results from our analysis. To date, we collected MRI data from 314 MS subjects and BDNF polymorphism in 193 subjects. Our analysis is focusing on the polymorphism, the BDNF polymorphism, and its relationship with the hippocampal volume and clinical progression of disability over time. So just a short focus on the hippocampus, that is, of course, an extremely important region of the brain for cognition and memory in particular, and is considered a neurogenic niche. It's a unique environment that hosts neural stem cells that can differentiate into neurons, oligodendrocytes, and astrocytes. And in multiple sclerosis, it is well documented that the hippocampus is severely damaged with severe demyelination, neuronal damage, and synaptic damage. The hippocampus plays its role through this neurotrophic factor, the BDNF, that is highly expressed in this region and has a number of key functions in neuronal survival, growth and differentiation, neuroprotection, synaptic plasticity, and modulation of neuroinflammation. So in a previous cross-sectional and small study, we found an association between the polymorphism of BDNF and the preserved volumes of the hippocampus, suggesting a potential protective role of this polymorphism. And we aimed to explore this hypothesis in a larger sample and in longitudinal study. These are the sample characteristics at baseline. We found the polymorphism in 68 patients. The characteristic clinical and demographic were similar. Only females were more represented in the non-carriers group. Also, the MRI characteristics at baseline were similar. We found, however, higher white matter volume in the non-carriers group, but importantly, again, we found a significantly higher hippocampal volume in the group carrying the polymorphism. And this is a focus on the specific subfields of the hippocampus that show a higher volume in the carriers of the polymorphism. In the longitudinal analysis, we found an interaction of the polymorphism with the time, and again, consistently with cross-sectional data, we found a lower rate of progression of hippocampal atrophy in those carrying the polymorphism. These are the subfields, the subiculum body, the hippocampal amygdala transition area, the hippocampal head, and fissure. Importantly, the carriers of the polymorphism exhibited a lower rate of disability progression during the follow-up. And in conclusion, the key findings so far, and our inference from these findings, we found this association, cross-sectional association at baseline between the presence of the polymorphism and the preserved hippocampal volumes. We confirmed in a longitudinal analysis this reduced progression rate of hippocampal atrophy in the carriers of the polymorphism that was also associated with the lower rate of clinical progression of disability. And we hypothesized that this polymorphism could have a protective effect, possibly due to enhanced brain plasticity and neurogenesis in the hippocampus, thus contributing to limit the evolution of clinical disability. Of course, we need to complete the assessment of other biomarkers and eventually to run this machine learning algorithm to find out the optimal combination of predictive biomarkers. And this is my last slide, acknowledgements to Rossella Marcucci and the group of collaborators. Thank you for your attention.
Thank you, Maria Pia. Excellent results. And then lastly, we go on the area of innovative treatment for improving preventive medicine, and I introduce Professor Baldini.
Good afternoon, everyone. Do you have a pointer? Okay. Thank you. I'm going to keep it short. I was told that I had only 3-4 minutes, so I'm going to just show you the rationale of the study and just some preliminary results. Okay, so what is the problem? Yearly, more than 300 million of people undergo surgery, require surgery. And of course, this is associated with significant morbidity and mortality. And of course, this has also an impact on our healthcare system, and indeed it is a significant burden for our healthcare resources. Moreover, we have to consider that our population is aging, and we know this is a major problem for Italy specifically. And with aging, patients undergoing surgery are exposed not only to an increased risk of complications and mortality, but to worsening of functional independence, worsening of quality of life, and worsening of their cognitive function. And of course, we can understand how these problems will also affect our healthcare system. So which is one potential solution of trying to solve or take care of this issue? Certainly the way how we identify surgical candidates has to improve, and we can not only consider chronologic age or our clinical comorbidities. So in the last year, there's been a lot of attention in focusing preoperative assessment, identify preoperative risk factors that are modifiable. So we're not talking about the presence of cardiovascular disease, diabetes, COPDs, and so on. We're trying to focus not only to identify high-risk patients, how we can modify the risk of these patients undergoing surgery. Of course, I'm talking about elective procedures. And we know from the medical literature, and this is not new, we know this since more than 50 years, that there are very modifiable risk factors that can be corrected before surgery, that have a very prognostic value, and identify those patients that will not go well after surgery. And these are functional capacity, cardiovascular fitness, respiratory fitness, malnutrition, anemia, all things that are very well represented in our surgical operation before the operation that currently we don't take care of, but that significantly impact on postoperative outcomes. So in the last year, there's been this novel concept of trying to address these factors in a multidisciplinary way. And this way has been called multimodal rehabilitation. And the aim of this project was really to see the feasibility of implementing a multimodal rehabilitation in high-risk patients undergoing major surgery at the Careggi Hospital in Florence. Therefore, we put together a multidisciplinary team, and that includes anesthesiologists, geriatricians, physiotherapists, kinesiologists, geriatrician, and psychologists, to try to address these modifiable risk factors. We empowered surgeons, oncologists, gastroenterologists, those who catch these patients way early in their diagnostic process, and we developed a preoperative screening questionnaires, self-reported by the patient, but gave them to our colleague surgeons and oncology and gastroenterologists the possibility to refer them way early in the preoperative pathway, trying to work on these modifiable risk factors. So there's you can see a screening phase that is done through the questionnaires that we have developed that we are currently validating on a cardiorespiratory fitness domain, nutritional domain, geriatric syndromes, cognitive function and psychologic function, and of course, lifestyle habits that might impact outcomes such as smoking and comorbidities. Then these patients are referred straight away to our multimodal rehabilitation clinic that with a lot of help from our hospital administration and university we were able to set up. And of course they are assessed in a more detailed and proper way on the same domains that have been screened. After the assessment, a personalized multimodal plan has been prescribed for this patient, taking care of cardiorespiratory fitness with aerobic and resistance exercise, correcting malnutrition when needed, if any in presence of malnutrition, but also supporting the cost of exercise, because if we ask this patient to exercise to improve their cardiorespiratory fitness, they need to have adequate nutritional support. Same time, we try to correct those geriatric syndrome and identify possible modifiable risk factor for delirium, falls, all things that frail and elderly patients might have during the preoperative period. And of course, we work on medical conditions such as anemia, implementing an IV iron infusion at the clinic without the need to sending them to the transfusion center. They might be a lot for these patients in terms of fitting their appointment during the preoperative phase. And then, of course, we reevaluate at the end of the period. On average, it lasts 4 weeks, and we try to see if the patient has improved, has deteriorated, did nothing change. And of course, we rediscuss the need of surgery in terms of not only of mortality and survival, but mainly in terms of quality of life and potential development of new disability and worsening quality of life. And to do this, we do a multidisciplinary meeting with our surgeons and oncologists. So this is the way how we are set up. You can see there's a gym where patients can do aerobic exercise when they come with resistance exercise with either physiotherapy and kinesiologist. They get IV iron infusion directly at the multimodal prehab clinic, and they are trained on average 3 times per week for a period of approximately 4 weeks. That is the optimal window, preoperative window, also regulated by our law to bring patients to the operating theater with cancer. But we also evaluate if this could be effective even in patients treated with neoadjuvant therapy. And why did we ask these questions to ourselves? Because the neoadjuvant therapy is an opportunity for further optimization. And on top of that, we know that neoadjuvant chemotherapy can worsen this condition. So paradoxically, these patients arrive worse than they were before to the surgery, and therefore are exposed to a higher risk of worse outcomes. So we look at this modality, here we are, sorry, in patients undergoing neoadjuvant therapy, and actually we saw that multimodal prehab worked very well. Indeed, this patient did not get worse in terms of nutritional status. They improved. Lean body mass also improved, and they did not lose strength, and they did not become sarcopenic. This is one of our patients with his chemo bottle during chemo, working out in our gym to avoid the deteriorating effect of a neoadjuvant therapy. But also we are looking a way to disseminate the need of getting fit to surgery on the community, because it doesn't make sense and we don't have the resources to treat all patients at the hospital. We want to sensitize the community, as other countries have done, to be able to help these patients after a multimodal prehab program has been prescribed, to do this next to their home in a dedicated center, rehab center, gym, because these patients, they can keep doing what they were doing before, even if they're waiting for surgery. And to do that, we need to regulate this new pathway, but also we need to have technology helping us to see what these patients can do at home. We are a referral center for many patients coming far away, and today we know that we have technology to understand what are doing these patients at home. Are they really following the prescriptions? Are they having problems to reach the intensity that we have prescribed to them? Are they taking nutritional supplements? So we are working with industries who help us to identify adherence, if the adherence to the project is good. So this is one of the technology that we use. You can see that we are able to monitor heart rate during aerobic exercise, but also we are able to monitor resistance exercise in terms of how many repetitions do they do. How long does it last? Can we increase the number of repetitions? Are they having problems to do certain exercises compared to others? So it's a tool that we definitely need to allow the implementation and to facilitate implementation of rehabilitation in the community without coming to the hospital 3 times a week. Overall, we have recruited more than 500 patients, and the results are very encouraging. I'm showing you the analysis on the first 143 patients. You see that in terms of function, measured here with a change in 6 minutes walking test from baseline. Before surgery, they improve, and at 30 days, they pretty much return to baseline with the 20 meters. That is considered the cutoff for return to baseline function. At 90 days are better than before. But you can see also in terms of lean body mass, loss of muscle mass, we see that these patients are catabolic up to almost 3 months after surgery. But these results are very encouraging for us, because despite the progression and the presence of muscle metabolism and protein catabolism, these patients don't lose function. So it means that somehow we were able to preserve their function despite their metabolic reserves are not optimal. Finally, I will just show you these results. We are trying to understand if this program is feasible, how elderly or frail patients are coping with rehabilitation. Most of the time we think that, oh, they can't exercise, it's too frail, it's too old. But actually when we look at surgical outcomes, so postoperative complication of patients, elderly, and these are patients who are older than 70 years old or 65 with frailty, and we look at those who respond to prehab by increasing their 6 minutes walking distance more than 90 meters versus those who were not able, the one who had a positive response. You see how strong is the impact of prehab in terms of severity of postoperative complications. This is encourage us to do not exclude this patient, but try to engage them as much as possible, because these are the patients who probably benefit most from prehab, especially in terms of complications and functional recovery. So I would like to thank all my team that help us to put this program together. These results have been presented last week to the Prehab World Congress in Melbourne. And I'm very pleased to announce that Florence will host the 2026 rehabilitation program. So it would be a further opportunity to help disseminate this new concept among the community. Thank you very much.
Thank you, Gabriele. And so the time is over. I want to thank all my colleagues, and I want to say again that it's a great honor for me to coordinate this spoke with it's so rich of excellent researchers and excellent projects. So avanti. Arrivederci.